Good evening.
Hi, sir. Good evening.
Good evening. Good evening.
Good evening, sir.
Good evening. Today you wanted to have some clippings.
Yes, sir.
Especially related to your DNB practical examination. So
Yes,
we'll have a few sessions on clippings, and today I have prepared about 30 clippings, and let us go one after another. It will cover electrocardiogram, then it will cover a few echo clippings, then hemodynamic data, then pressure tracing, and one or two angios. So altogether it will be a mixture, and we'll have similar programs, 2 or 3, so that before you go for your practical examination, we have enough time to train you.
Yes, sir. Yes, sir.
So let's go with the first one to get some. I will project a clipping, and anybody can give a comment about the clipping.
So we can't see.
Can you see my screen?
Yes, sir.
Yes, sir. Yes, sir.
Okay. Okay. First is an electrocardiogram, opinion, diagnosis, and management.
Yes.
You have to tell the diagnosis and then tell the management.
Okay, sir.
You should give the reason why have you made such a diagnosis.
Sir, it's a 12-lead ECG with a normal standardization.
No, don't say, no need. You just tell the diagnosis, because this is a spotter session. You tell the diagnosis and tell me why you have made that diagnosis. Okay.
Sir, it is a left anterior fascicular block.
Not enough. No. Anybody else?
Sir, Sir Saroj here, sir. Sir,
Yeah,
good
yeah.
evening. Sir, the ECG is showing, sir, the P waves and the QRS complexes, they are not maintaining any relation.
Why did you say that? They are maintaining a correct relationship.
Yes, sir. Sorry, sir. In the one lead eye. Sir, this is a complete left bundle branch block with increased PR interval, and there is also left axis deviation.
No, wrong. Anybody else? See, in such an ECG, the diagnosis is, I will tell you how to write the diagnosis. Here it is a trifascicular block with anterior wall myocardial infarction or previous anterior wall myocardial infarction. That is the full diagnosis.
Okay.
Why there is a trifascicular block? Any one of you?
Sir, in lead V1, QRS is positive. R wave is positive. Then again in lead 2, it's showing a LBBB pattern. And in inferior leads, it is in lead 2.
No, what do you mean by trifascicular block, first of all?
Sir, it is a the branch in conduction system in LBLB, the left bundle branch has two pathways, like left anterior pathways and left posterior pathway. So there is a block, there is a degenerative changes that will causes the trifascicular block.
The bundle of his divides into the right bundle and the left bundle, and the left bundle, which is the thicker bundle, divides into anterior fascicle and posterior fascicle. And these three fascicles, there is the right bundle branch, the anterior fascicle and the posterior fascicle, are considered as the separate fascicle, and that is what is meant by trifascicular block.
Right.
So you should have evidence of involvement of all these three fascicles for you before you say there is a trifascicular block. So in this electrocardiogram, what is the evidence of all these three fascicular involvement?
Sir, V1 and V2, it's showing LBBB and RB, alternate LBBB RBBB pattern.
Where is an alternating LBBB and RBBB pattern?
There is a transition of R wave to S wave in V1.
So what? It can be due to anterior myocardial infarction. What does the V1 show? Is
Positive
it
R
RB?
wave.
Is it
R wave.
QR wave, sir. QRBBB.
Yeah, this is an RBBB. And there is a left axis deviation.
Yes.
And what is the axis in this patient? If you take 0.06 seconds, or if you take the, what is the axis in this patient?
Sir, near about 45.
What is the axis?
Sorry.
What is the axis?
Around 70, 80, sir.
70, 80, plus or minus?
Minus, sir.
Plus.
Minus. Around, it is actually beyond, it is near about minus 60. Because it is negative in lead 2, lead 3, AVF. Everywhere it is negative. And probably, if you want, you can put AVR as equiphasic. In that case, it is around minus 60. And what is the PR interval?
So PR interval is more than 200 milliseconds.
Yeah, it is prolonged.
Prolonged.
So, what is the evidence of trifascicular block in this patient? The patient is having right bundle branch block.
Right bundle branch block with left axis deviation. LAP is there.
Left anterior fascicular block and prolonged PR
And PR prolongation.
There is a posterior fascicular block also. And in the electrocardiogram, V1 shows a Q wave in V1. There is a Q wave. There is a very rudimentary R in V2, and even in V3 the R is very insignificant. The presence of a Q wave in V1 in a patient with the right bundle branch block pattern usually indicates a previous anterior myocardial infarction. So this patient, and the patient is having even a Q wave in V5. The R wave is not rising from V2, V3, V4, almost up to V5. And there is a Q wave in lead V1. So the full diagnosis is that this patient is having a trifascicular block with the previous anterior myocardial infarction. The evidence for trifascicular block is the electrocardiogram showing right bundle branch block, the electrocardiogram showing left axis deviation indicating left anterior fascicular block, and along with that there's a first degree heart block indicating the third fascicle also is involved. And the presence of Q wave in V1 and also the failure of R wave to develop even up to V5. V5 is not classically a Q wave, but there's a rudimentary R. All indicate that patient might have had a previous anterior myocardial infarction. Management. What is the problem of these patients and what is the management?
Usually this patient present with old age patient degenerative changes presenting with syncopal repeated syncopal attack.
This is not a degenerative change. Most likely it maybe degeneration also may be playing a part, but ischemia also is playing a part. Both. Okay. So what is the management?
So usually patient presenting with a complaint of syncope, repeated history of syncope. If patient is symptomatic and a repeated episode of syncope, then patient need a permanent pacemaker.
Very good. These patients with a trifascicular block are likely to develop complete heart block because already all the three fascicles are involved, and there is a good possibility that these patients may progress to complete heart block. So when if there's a history of syncope, then these patients require permanent pacemaker implantation. Okay, right. We'll go to the next one.
So should we do first angio and anterior wall? There is maybe anterior wall MI that we need to revascularize, sir.
Well, you can angiogram and all those things can be done, but if the patient is presenting with the discussion is based only on the electrocardiogram. I didn't go to the discussion about the anterior myocardial infarction. The patient's main problem is a trifascicular block, and if he is presenting with evidence of complete heart block and syncopal episodes, then he requires a pacemaker implantation. It is worthwhile doing is an old case of anterior myocardial infarction as evidenced by the electrocardiogram, and it may be worthwhile doing an angiogram and trying to find out echocardiogram to find out whether the septum is how much is the septal damage, whether septum is fibrosed, and also you can do an angiogram to look at the coronary anatomy, and any revascularization process can be done. I agree with you that when there is a revascularization process, there is a possibility that the damage to the third fascicle, because that third fascicle is the one which is conducting the impulse, may be even delayed. But once he presents with the syncopal episodes and which is suggestive of complete heart block, he will require a permanent pacemaker implantation. He actually presented with an episode of syncope, and we had to put in a permanent pacemaker on him.
Okay. Okay, sir. Thank you.
Okay. Right, next one. Try to analyze, give the diagnosis, and support the diagnosis with the evidence. See, in the when you are having a spotter, that is the way you may have to answer. You have to write the diagnosis, support the diagnosis with the reason, and then there may be a question about what would be the management. So you have to write a sentence about the management also.
Sir, atrial bigeminy.
Atrial bigeminy. What do you mean by atrial bigeminy?
Sir, QRS alternately, sir, narrow QRS and the white QRS complexes are seen. And sir, before each QRS, we are seeing the P waves. Sir.
Okay.
Sir, so
are they regular or irregular?
Sir, they are regularly coming, sir.
Oh, so then you cannot use the word atrial ectopic. So, why did you use the word bigeminy? Bigeminy is actually group beating. Two beats come together, then there is a gap, then two beats come together, then there is a gap, two beats come together. That is the one which you call it as bigeminy. Here there is no bigeminous rhythm. So, but the QRS morphology is going on changing. Whenever the QRS morphology is going on changing, you should always observe lead V1. Lead V1 is the best lead to make out why this pattern is changing. What is, you look at the lead V1 and what do you think about it? Well, the top one is a lead V1, so there is no problem because a short rhythm script is given.
Then alternately bundle branch block is changing, sir.
Yeah. So the one is a, well, this is suggestive of the first QRS combination. Let me see where I get. The first QRS complex is a left bundle branch block pattern, and the next one is more like a right bundle branch block pattern. I fully agree with you that it is not as broad as the left bundle branch block, but it is, the pattern is more like a right bundle branch block. So it is alternating left bundle with the pattern. See, here it seems to be slightly wider and may even be interpreted as the left bundle, right bundle branch block. So there is a suggestion that this is an alternating left bundle and right bundle block, right bundle branch block, left bundle branch block, right bundle branch block. Okay, what else is there in this patient? Saroj?
Yes, sir.
What else is there?
There is, sir, ST elevation is also seen, sir.
Very good. That's ST elevation. So this, yes, so this patient is presented with a ST elevation. ST elevation myocardial infarction, because he has got ST elevation in V1 also is seen, then V3, V4, everywhere you can see significant ST elevation. So this is an ST elevation myocardial infarction with alternating right bundle and left bundle. So he also has got a trifascicular block, but he's in acute phase of myocardial infarction. So what is the management? So what would be the management?
Sir, we have to do early revascularization, sir.
Very good. Because he has presented with a ST elevation and a complication of a bifascicular by alternating right and the left bundle branch block, and he can at any moment go in for a complete heart block. He should be taken up immediately, an angiogram to be done, and he has to be revascularized. And revascularization may help to salvage even the conduction system, not only the myocardium, sometimes the conduction system also can be salvaged. So this is another example of a trifascicular block. There is alternating right and the left bundle branch block. And on top of that, the patient is presented with acute ST segment elevation myocardial infarction, and the management would be immediately taking up the patient for a primary PCI angiogram and then deciding the procedure depending upon the angiographic findings. Most likely, he must be having an LAD. I don't remember about this patient. Most likely, he must be having an LAD occlusion, and a procedure of opening up the LAD sometimes may salvage even the conduction system to some extent. Not only the myocardium, but the conduction system also may be salvaged. Okay, any doubt?
No, sir.
If you have got any doubt, you can ask. Okay, we'll go to the next one. You must tell the diagnosis. And tell why did you diagnose. A rhythm strip is given, so mostly it is given the ECGs for the interpretation of the arrhythmia. On top of the arrhythmia, if there is something more, that also should be mentioned.
This is complete heart block with QRS complexes of LBB morphology.
Okay, QRS complex of LBB morphology. What are the diagnostic features of complete heart block, Saroj? There are 4 diagnostic features.
Yes, sir. Sir, the PP interval is fixed.
Yes.
RR interval is fixed. The PP interval is shorter than the RR interval, and there is no relation between the P and the R.
Yeah, there is a 4 points. One, PP is regular, RR interval is regular, P rate is more than the QRS rate, and there is AV dissociation. PR interval goes on changing. Okay, you look at here. Is it regular? Look at the rhythm. Is it regular?
So RR interval is changing.
RR interval is changing. So you cannot consider a complete heart block as a possibility because RR interval should be regular.
Yes.
Here the RR interval is changing.
Yes, sir.
So what is the arrhythmia here?
Then
Second degree AV conduction.
Mobitz Type 1 heart block.
Yeah, Mobitz Type 1 or a Wenckebach phenomenon. And you must mention Wenckebach what? Is it 4:3, 3:2, 5:4, 6:5, or 2:1? What is the level of Wenckebach?
He has
3:2.
3:2. See, how do you measure it? You must first look at the first conducted P wave. This is the conducted P wave. 1. Till the time the P wave is dropped. So 1, 2, 3. So this P wave is not conducted. This is the one which is conducted. So this P wave is dropped. So there is 1, 2, 3. 3 P waves and 2 QRS complexes. 1, 2. So this is a 3:2 Wenckebach phenomenon. And as Saroj just rightly said, the patient is having associated left bundle branch block, and which is maybe pre-existing. And some people even have described Wenckebach in the left bundle branch, but that you need not worry. You can tell that the most likely the bundle branch block is pre-existing, and the patient has got a Wenckebach phenomenon. Okay, right. Anything else in this electrocardiogram? No. So he has got an associated left bundle branch block and a Wenckebach phenomenon. Okay, we'll go to the next one. This is simple. I think you should be able to diagnose without any difficulty.
Sir, ventricular tachycardia.
Ventricular tachycardia. Why did you diagnose ventricular tachycardia?
Sir, there is a AV dissociation,
Yes.
and yes, sir, there is AV dissociation.
No, first you should say it is a broad QRS complex.
Broad complex QRS with AV dissociation.
So you can see this is you can see the the atrial contractions can be seen, which is not unrelated to the QRS complex, and it is slower than the QRS complex. In ventricular tachycardia, the P rate will be less than the QRS rate. So the PR the PP interval will be more than the RR interval, indicating that it is slower. So the ventricular tachycardia is diagnosed by broad QRS complex tachycardia, AV dissociation, and also the ventricular rate is more than the atrial rate. If the atrial rate is more than the ventricular rate,
then it is AVRT, sir. Atrioventricular reentrant tachycardia.
no. If the atrial rate is more than it is not reentrant tachycardia. Sorry.
So AF with broad QRS complex is like AF with LBBB.
No. I'm just telling you. I said the P rate is less than the QRS rate. If I am telling you that if the P rate is more than the QRS rate and you are finding a more broad QRS complex tachycardia, what is your diagnosis?
AF.
WPW with.
Whenever there is when there is a P wave is the P rate is more than the QRS rate, it is an abnormality in impulse conduction. When the QRS rate is more than the P rate, it is an abnormality in impulse formation. So the ventricular tachycardia is an abnormality in impulse formation, and if the P rate is more than the QRS rate, it is an abnormality in impulse conduction. So you have to think of a conduction abnormality, whether there is an abnormality of conduction across the AV node, whether there is a conduction abnormality. That is what you have to look at. So whenever you are seeing a broad QRS complex tachycardia, you must always look at the P wave also. If the P wave is less than the QRS rate, then you are sure that it is a ventricular tachycardia. But if the P rate is the same as QRS complex and you are seeing that it is negative in lead to 3 AVO, then what is the diagnosis? The broad QRS complex tachycardia. P waves are seen. Each QRS complex is followed by a negative P wave
with aberrancy. SVT with aberrancy.
When
Isorhythmic AV dissociation. Isorhythmic AV dissociation.
No. When there is each P wave is when there is a ventricular there is a tachycardia. It's ventricular tachycardia. I'm saying this is ventricular tachycardia. What is the condition in which there is a ventricular tachycardia? And 1:1
condition.
1:1 retrograde conduction. The P is being retrogradely conducted, and that will be recognized by negative P waves in lead to 3 AVO. Tell me the situations where there can be broad QRS complex. Broad QRS complex tachycardia. What is the differential diagnosis? One is ventricular tachycardia, commonest. What else?
Sir, AVRT.
AVRT or AVRT or NRT. Sorry, not even AVRT associated with
atrial fibrillation. Sorry.
Regular tachycardia.
Sir, AVRT antidromic conduction.
AVRT antidromic conduction. Then AVNRT
with pre-existing bundle branch block.
Yes, pre-existing bundle branch or tachycardia induced bundle branch block. Sometimes you can get tachycardia induced bundle branch block. So the tachycardia induced bundle branch block. So these are the things you should consider. One, ventricular tachycardia. Two, antidromic AVRT. Then AVNRT associated with pre-existing bundle branch block, or it could be a tachycardia induced bundle branch block pattern. So these things you should always consider as the differential diagnosis, and then only you should finally say the final diagnosis. So what are the points by which you will be able to differentiate a broad QRS complex tachycardia is ventricular tachycardia, or is it a other form of tachycardia in the form of antidromic conduction or WP or bundle branch block pattern? How will you differentiate?
Sir, there is Brugada criteria is there, sir?
Yeah, please. Okay, very good.
Any RS complex in if there is any RS complex in precordial lead, it favors in favor of SVT with aberrancy.
Okay, very good.
Then
It is
Then-
more, it is, oh, yeah. When there is an RS complex in the precordial leads, that's a point against the diagnosis of ventricular tachycardia.
yes, sir.
Okay.
Then, next is
Sir, there is a fusion beats or capture beats or both.
If there are fusion beats or capture beats, that's strongly in favor of
Ventricular
ventricular
VT.
tachycardia. Okay, right, very good.
Then extreme
AV
axis,
dissociation.
Extreme.
axis deviation.
Okay, axis in the right upper quadrant, or extreme left axis deviation goes in favor of ventricular tachycardia. Okay, what else?
AV dissociation
AV
goes in
dissociation,
favor of ventricular tachycardia.
yeah, very good. And also duration of the QRS complex.
More than one.
More than 160.
Oh, more than 160
favor.
is too much. You need not go for
120.
no, 120 is not enough.
140, sir.
140. It's 140. If it is more than 140 milliseconds, that is strongly in favor of ventricular tachycardia. So these are the minor few points by which you can always differentiate ventricular tachycardia. But in a QRS, in a broad QRS complex tachycardia, where you find it extremely difficult to differentiate from the various forms of broad QRS complex tachycardia as a whenever you find there is a broad QRS complex tachycardia and you are not able to differentiate, always go for ventricular tachycardia. Okay, so ultimately, if you are not able to differentiate clearly from the electrocardiogram, you should go for ventricular tachycardia. Okay, right. Yes, next one. Ronak, are you there?
Yes, sir.
Ronak?
Yes, sir. Sir, P wave is not conducting, sir. Sinoatrial block.
Okay, P wave, are you able to see the P wave?
No, sir.
Previous are not seen.
Then why did you say P wave is not conducted? There is a P waves are not seen.
P waves are not seen, sir.
Okay.
Sinus node dysfunction.
Sinus
Tall
nodes,
waves,
Okay, sinus not.
tall T waves are seen, sir.
Oh.
Whether hyperkalemia.
Yes, very good. It is a case of hyperkalemia.
Hmm.
And what is the arrhythmia seen in the rhythm strip?
So they are sinus node dysfunction.
Yes.
That can be a sinus exit block or a sinus pause. So
Yes.
looks like a sinus pause.
Okay. It can be hyperkalemia is associated with absence of P wave, atrial paralysis, and sinoatrial conduction abnormalities. Sometimes people even describe it as the conduction can be from sinus node to the AV node. Or it is even said that it could be sinus node to bundle of his conduction. So the absence of P waves, then the tall peak T waves, then some degree of sinoatrial conduction abnormality, all these points towards the diagnosis of hyperkalemia. And what do you think would be the potassium level in this patient?
5.5 to 6.5.
More.
Can you tell me the various patterns of electrocardiography changes in hyperkalemia? What is the first one?
Tall T wave.
Tall T waves. Then
Loss of P wave, absent P wave.
loss of P waves. 3.
Then sine wave pattern.
No, that is later. Before
Broadening
that,
of QRS complex.
Broadening of QRS complex.
before that, you can even say the sinoatrial block, widening of the QRS complex, and sine wave pattern.
Sine wave pattern.
So usually, sine wave pattern is usually around 7.5 to 8, and this pattern is usually anywhere between 7.5. So at that level, the sine wave pattern is usually above 7.5, maybe about 8, and these patients are at risk of developing ventricular fibrillation. Okay, so this is a very good, Saroj, very good. This is a case of hyperkalemia. Diagnosis and management.
Brugada pattern.
Brugada pattern, very good. Can you describe what is Brugada pattern?
Sir, Brugada pattern, sir, it looks like an incomplete RBB with terminal slurred sir, the R waves.
Yes, there's a usually V1, V2, V3 may show a broad bundle branch, like right bundle branch with like a QRS complex with a saddle shaped ST elevation with a T wave inversion. That is suggestive of Brugada syndrome. What is the Brugada syndrome? What is Brugada syndrome?
Symptomatic with ECG changes.
No, you have to use the correct word. It is a
Incomplete RBB with ST elevation, patient with a history of syncope or maybe survival of sudden cardiac death.
okay. That's right. But what is it? What is in the disease process? What is it classified as?
Channelopathy.
Channelopathy. That is a sodium channelopathy. It is a sodium ion channelopathy. Is a Brugada syndrome and is associated with electrocardiography changes, both involving the QRS complex, the ST segment, and the T wave from V1 to V3. And why we are worried? It is associated with
Fatal ventricular arrhythmia.
ventricular arrhythmia, sudden cardiac death.
Sudden cardiac death.
So these patients may require
ICD.
ICD implantation. How will you decide the need for ICD implantation?
Sir, there are three types, type 1, 2, and 3. If the pattern is type 1, patient and history of syncope or survival of sudden cardiac death, patient has a, he required it is a level, what?
So those patients with type 1 Brugada electrocardiographic pattern associated with a history of a sudden loss of consciousness or survival of a sudden cardiac death, or a strong family history of a similar episodes in the near relatives.
You required ICD implantation. And another is in type 2, if patient, if it can be precipitated by fever, or if it is changed from type 2 to type 1, then those patients also required ICD implantation.
Okay, very good. These patients can be the patients with sometimes the type 1 pattern can be brought out by conditions like fever, infection, all those things. And certain drugs also can bring it out. What is the name of the drug?
Quinidine group and flecainide.
Procainamide can actually bring out the Brugada pattern from type 2 to type 1. Type 1 is the one which has got the risk of developing major arrhythmias. Type 3 also does not have the risk. It has to manifest at least sometime type 1, then only they have got the risk of developing ventricular arrhythmias and sudden cardiac death. And if there is a family history, or if the patient himself gives a history of a syncope, unexplained syncope, or a survival of a sudden cardiac death, those patients require ICD implantation. Okay, it is a channelopathy. When you are asked a question, what is Brugada syndrome? The answer is it's a sodium channelopathy and it's associated with electrocardiography changes in V1, V2, V3 involving the QRS complex, ST segment, and the T wave. And type 1, type 2, type 3. Type 1 is the one associated with the broad QRS, ST segment elevation, and saddle shaped ST elevation with the inversion of the T wave, which is associated with the risk of arrhythmias and sudden cardiac death. And these patients with a family history requires ICD implantation, or the patient himself gives a history of loss of consciousness. This patient came to me. He was a 30-year-old gentleman who's because of a non-cardiac chest wall pain, a routine electrocardiogram was done, and this pattern was detected. So he was referred to me. I had great difficulty to decide what should I tell him. So if I tell him that this is a disease in which there is a risk of a sudden cardiac death, I think he will become extremely anxious. So I told him that as such, this abnormality can be at the moment ignored because he was asymptomatic. And I told him that you please come for a follow-up, or if you develop at any time loss of consciousness, you should immediately come to me so that we can do something about that. And this is now about 12 years now. and is just normal. He continues to have this pattern, but he did not have any arrhythmia. So all patients need not go for any malignant ventricular arrhythmias, but you should have evidence of ventricular arrhythmia before you advise an ICD implantation in these patients. Okay, any doubts? Okay, we'll go to next one. Okay. What is this? This many of you might have already seen previously. So it would be easy for you to diagnose and tell me the management.
High-grade AV block.
High-grade AV block. Would you like to give a name to it?
The PR interval is fixed, so it will be type 2.
Type 2. Oh, no, what type 2?
Mobitz type 2, sir.
Yeah, it's a Mobitz type 2 AV block. Very good. It's a Mobitz type 2 AV block. You can see that the patient is having a broad QRS complex. It's a monitor lead, so you can't be certain about which bundle is involved. So he has got a broad QRS complex, and he's having a fixed PR interval. And suddenly, at this level, the P wave fails to conduct. 1, 2, 3, 4, 5, 6, 7, 8, 9, and then only the 10th P wave is conducted. So he's having a sudden failure of the P waves to generate a QRS complex. And this is the classical feature of Mobitz type 2 block. And following that also, after recovery, still is having 2:1 block. And after a few cycles, he settles down for a normal conduction. So this is usually it is associated with infra-ECM type of a block. There can be sudden failure of conduction of the Q wave, and these patients can develop loss of consciousness. They can develop, they can go in for a sudden cardiac death. And these patients, once they have got evidence of Mobitz type 2 block, they should be recommended for pacemaker implantation. So this is a classical Mobitz type 2 block, and the treatment is pacemaker implantation. Okay, we'll go to next one. This is symbol.
WPW syndrome.
WPW syndrome. You have to classify it type A, type B, and where is it going, and can this be associated with any disease process?
And here it is left, right side.
Right side. It is going to the right side. Okay. Right side where?
Sir, it is from free wall to lead 2, 3 AVF is negative. So it means it is going from towards base. So from free wall towards base.
Is it free wall to base, or is it suggestive of posterior part of the? It is a postero apical pathway. It is starting from the posterior portion. See, whenever this lead to 3 AVF is negative, it indicates that it is going up. And when it is free wall, what will be the pattern? If it is an RV free wall, what will be the pattern? What is the difference? AVF will be
the isoelectric AVF.
It can be even positive. It's a here AVF if it is negative in a patient with type B WPW, where it is going to the right ventricle, and if it is showing lead to 3 AVF negative complexes, then it is a posterior septal pathway.
Okay.
The posterior septal pathway. The anterior free wall pathway AVF will be positive. Lead 2, lead 3 will be negative. AVL will be positive, and AVF also will be positive. Here AVF also is negative. So this is a right posterior septal pathway. And what is the condition associated with type B type of WPW?
Epstein.
Epstein, yes, Epstein's anomaly. When they can, about how many percentage of patients with Epstein anomaly can have WPW?
15%. I'm not sure.
Around 15%. You are right, correct. Around 15% of patients with Epstein's anomaly can have WPW, and it is usually a right-sided pathway. Okay, right. Very good. Excellent. Okay. Somebody else can try now. Okay. What is arrhythmia and what is the management? What is the arrhythmia and what is the management?
So sinus tachycardia.
Sinus tachycardia. Why did you say it is sinus tachycardia?
P wave followed by QRS complex.
How do you diagnose sinus tachycardia? How do you diagnose sinus tachycardia?
Sir, normal axis P wave followed by QRS complex. That is in V1, the initial part of the P wave is positive, then there is a negative deflection of P wave followed by QRS complex.
Okay. See, what is by looking at the limb leads, what is the simplest method by which you can diagnose that this is a sinus P wave?
Sir, in lead 1, P wave has to be positive.
Lead 1, it has to be positive, but more important is lead 2 should be positive, and usually the tallest P waves in a sinus rhythm will be seen either in lead 2 or it may be negative in AVR. So these are the two leads where you get the most prominent P waves in a sinus rhythm, and lead 1 has to be positive. Here is this the pattern? Anybody else would like to have any different thought process? First of all, do you think that is it a normal sinus rhythm, or do you think that there is an arrhythmia? Saroj, would you like to try?
Sir, this is an arrhythmia because, sir, the heart rate is very high. It is around 150. And sir, number two.
That year said it is sinus tachycardia, because there can be sinus tachycardia which rate can go up to 160.
And sir, sir, there is a doubt whether the P waves is present in the sir. One said that in AVR it is positive, whereas in lead 2 it is negative, sir. If the P wave is preceded by the QRS, but sir, there is also some doubt in the terminal part of the QRS complex. Some notching is coming. Whether which one is the P wave is a little confusion that whether the P wave is
when the heart rate is, what is this heart rate? This patient's heart rate?
150.
150. Okay. When the heart rate is 150 or when the heart rate is 75, what is the condition you should suspect?
Sir, I have to suspect, sir, flutter, sir.
Flutter, yes. Whenever you are having a patient, the rhythm rate is 150 fixed and 75, then you should always suspect flutter, because usually the flutter atrial rate is around 300, and usually they have either 2:1 conduction or 4:1 conduction, and a heart rate of 150 or 75 should immediately make you suspect that patient may be having atrial flutter. And do you think that this patient is having atrial flutter?
Yes, sir.
Yeah, you can clearly see that the patient is saying this is a flutter wave. This also is a flutter wave. Actually, what we are seeing after the end of the QRS complex is a flutter P wave. So this is the flutter wave. This is a flutter wave. So he's having an atrial flutter. Is he having any other problem like ischemia or anything?
Sir, there is a early transition of QRS complex in lead 2 and followed by dominant R wave in V4, V5, V6, probably having left ventricular hyper with ST depression, LV strain pattern, left ventricular hypertrophy. With this pattern is also early transition. There is a subaortic VSD as well. It could be subaortic VSD.
I can't be certain. I don't know. I don't remember about this patient, but I don't think we can diagnose subaortic VSD because subaortic VSD is not usually associated with atrial flutter. Atrial flutter usually occurs in ischemia or a valvular heart disease like mitral disease. So, or it may sometimes can occur in patients with amyloidosis, or so these are the conditions where you can get a atrial flutter. So, and also electrocardiographically, I cannot diagnose left ventricular hypertrophy. Why did you diagnose left ventricular hypertrophy? Because by QRS complex, the height of the QRS complex is not enough to diagnose left ventricular hypertrophy.
Yes, sir.
So I cannot diagnose left ventricular hypertrophy. There are some STT changes, but those changes can be because partly may be related to arrhythmia, may be related to increase in the heart rate. So that may not definitely indicate a strain pattern. So I will not make a diagnosis of LVH with strain. I will describe it, but I will not draw any conclusions. So this patient has got evidence of a atrial flutter, 2:1 block, and flutter waves are well seen in lead 2-3 AVF. So is it a what type of flutter is it?
This is typical, sir.
Typical. It's a typical flutter. And what is the relevance of typical flutter?
The typical flutter, they are, sir, ablation can be done.
Yes. Why?
Because, sir, their location is important. Sir, the 2-3 AVF is negative. It means, sir, we can ablate the, sir, I think triangle of Koch or pulmonary vein isolation. Sir, I don't remember.
No, there's no need of pulmonary vein isolation. Usually, when the patient is having the flutter waves are well seen lead 2-3 AVF, that usually means the re-entry is in the region of the Koch triangle. Koch triangle.
Koch triangle, yes.
Koch triangle, and these patients are amenable to radio frequency ablation. As against the atypical flutter, where the flutter waves are best seen in lead V1, in lead V1. And the problem in atypical flutter is that these patients have multiple re-entry sites, not in the region of the Koch triangle, but anywhere in the atrium, and hence they are not amenable to radio frequency ablation. So you have to differentiate between typical and atypical flutter. Typical flutter is associated with flutter waves most prominently seen in lead 2-3 AVF, and these patients have got their re-entry circuit in the region of the Koch triangle, and these patients are amenable for radio frequency ablation. As against the atypical flutter, where the abnormal the flutter waves are best seen in lead V1, and they have got multiple areas of re-entry, either in the intraatrial septum or in the various parts of the atrial musculature, and these patients are not prone for, those patients are not amenable for radio frequency ablation. So this patient is an ideal candidate for radio frequency ablation if his problem cannot be controlled with the medication. Many times atrial flutter can be controlled with medication and need not go in for radio frequency ablation. But if the atrial flutter is troublesome and the patient is getting recurrent episodes of tachycardia and there is a risk of thromboembolic complications, these patients can be subjected for radio frequency ablation, and their response to radio frequency ablation is excellent. If the patient is having hemodynamic disturbance, then the management is
DC shock.
DC shock.
And what is the current that you use?
Sir, only 25 joules.
You can use a minimum current. Very often
synchronized
synchronized DC cardioversion with a current of even 10 joules may be enough, 10 joules per second, or you can go up to 25, and that is more than enough to convert the patient to normal sinus. They respond very well to DC cardioversion. Excellent. Very good. Okay. What is this?
Pulses alternance.
Okay. Very good. A pulses alternance. How can you diagnose pulse alternance by electrocardiogram?
Alternance, that low voltage QRS
Low
complex,
voltage complex.
Low voltage QRS complex associated with
possibly tamponade, sir.
tamponade. Very good. It is a case of cardiac tamponade. You got low voltage complexes with electrical alternance. Actually, to diagnose by electrocardiogram, what is the criteria? What is the finding which can definitely tell you that this is cardiac tamponade? This patient had cardiac tamponade, but what is the electrocardiographic criteria? Which, if it is present, definitely you can diagnose cardiac tamponade.
Sir, in lead V1, the R wave height of the R wave is in first part is followed by second part is more than 50%.
No. There's nothing.
Lead V3, sir.
Eh?
Sir, in lead V3, sir, we are seeing the QRS complex. Sir, from the lead V3, I think we can diagnose the QRS morphology is totally changed. So the heart is just moving.
No, the electrical alternance is because of the movement of the heart. But then, if you want to diagnose cardiac tamponade from the electrocardiogram, you will need total electrical alternance.
Yes.
What do you mean by total electrical alternance?
All the waves, sir, P, QRS, and T, all will be changed, sir.
Yeah. So if you are seeing alternating P, QRS, and T wave in the morphology, especially the size of the P wave, size of the QRS, and size of the T wave is alternating. That is known as total electrical alternance is diagnostic of cardiac tamponade. If you find that, it's 100%. But it's extremely rare to get it. But if you are seeing a low voltage complex and along with that QRS alternance, then you should strongly suspect that the problem that you are handling is cardiac tamponade. So this patient actually had cardiac tamponade. The patient has got low voltage complexes throughout limb leads as well as chest leads, and also the patient has got evidence of electrical alternance of the QRS complex. So this patient, the condition you should suspect is cardiac tamponade. Okay, right. Yes. Next one. What is the condition that you should suspect? Some red line has come. Okay, there is a by Gemini. There is no doubt that there is a group meeting. So can you tell me what are the arrhythmia situations where there can be bigeminous Sudar? There are 5 of them. Can you mention that, any one of you?
Sinoatrial block.
Okay, sinoatrial block. That need not be the first one. Okay, there is a sinoatrial block, yeah. Especially if there is alternating sinoatrial block or a 3:2 sinoatrial block. Okay, right? Yes. 1, 2.
Sir, Wenckebach phenomenon.
No, that is not enough. You have to mention what Wenckebach phenomenon.
Sir, 3:2.
Very good. 3:2 Wenckebach phenomenon. Very good. Excellent. Any other condition?
Sir, atrial flutter with blocks, sir, that will be also 3.
You are right. Atrial flutter with 4:1, 2:1 block.
Yes.
Alternating 4:1, 2:1 block, there will be group beating. Very good. Excellent. Yes. Next one. The commonest you have not mentioned.
Atrial arrhythmia.
Not atrial arrhythmia, alternating ventricular atrial ectopic with normal beat.
Bigeminal,
Always
ventricular bigeminal.
always say a normal beat followed by an ectopic beat.
Ectopic.
Normal beat followed by an ectopic beat. Yes. Fifth one is
Alternate VPC.
that we already mentioned. Alternate VPC. Either atrial or atrial or ventricular VPCs. Not atrial VPC or APVPC. The ventricular premature contractions or atrial premature contraction. Both can happen.
Mobitz type 2 also, sir, if it is 2:1.
No. 2:1 we already mentioned. Wenckebach phenomenon. Another is escape capture by Gemini.
Yes, sir.
Because in a patient with sinus no dysfunction, sometimes there can be an escape beat that can be followed by a capture beat.
This is escape capture.
Yeah, this is actually an escape capture beat. You can see that this is actually an escape beat. This is an escape beat, then followed by a P wave, and it's a capture beat. So this is a bigeminous rhythm with escape capture bigeminy. So there are five situations where you can get escape the bigeminous rhythm. That is one, alternating ectopic beat, normal beat, ectopic beat. 2, 3:2 Wenckebach phenomenon. 3, atrial flutter with 4:1, 3:1, 2:1 conduction, alternating. 4, sinoatrial Wenckebach. Sinoatrial Wenckebach and also can have 3:2. 3:2 sinoatrial Wenckebach or sinoatrial block can behave sometimes like can generate group beating. And finally, escape capture bigeminy. So these are the situations where you can get bigeminous rhythm. So this is actually escape capture bigeminy. Okay. Diagnosis?
This is also hyperkalemia, sir. Sine wave.
Yeah, very good. It's hyperkalemia, and you can see the sine wave pattern. See where the QRS, there is no ST segment. QRS merges with the T wave, and you cannot distinctly see the P waves. So this is actually a sine wave pattern in a patient with hyperkalemia, and the patient's the level of potassium will be anywhere above 7.5. It can be 7.5 to 8 milligrams per liter. So this is a case of hyperkalemia. Very good. Hello, technical team, are you there? There is a, on the screen, there are 2 red lines. Can you remove that? Technical team, are you there? Okay, right. Yes, does not matter. Okay. What is the
bundle branch block? Sir, rate related bundle branch block?
No. What is this arrhythmia? You can see the broad QRS complex, you can see fusion beats, then you can see normal conduction, then again it goes to broad QRS complex. What is the arrhythmia? The CC, you might have seen this arrhythmia.
So idioventricular rhythm.
Yes, sir.
Accelerated idioventricular rhythm.
Idioventricular rhythm.
Accelerated idioventricular rhythm. And classically, this can happen in what situation?
Reperfusion.
Reperfusion arrhythmia.
Reperfusion arrhythmia. So in patients who have received thrombolytic therapy or immediately after primary angioplasty, you may be able to see this arrhythmia in patients who have just been reperfused. So this is a reperfusion arrhythmia, and this is an accelerated idioventricular rhythm. And classically, previously this is also classically seen in patients with inferior myocardial infarction, where there is an increase in the vagal tone. And classically now we see in patients after reperfusion, it is a reperfusion arrhythmia, accelerated idioventricular rhythm. Okay. Diagnosis.
So type 3 SA sinoatrial block.
Type 3.
Hmm.
What do you mean by type 3 SA block?
P wave is not conducting.
The PO is getting conducted. You can see the
Sinus node dysfunction. It
Oh.
may be, sir, either exit block or sinus pause. Sir, we have
Okay.
to measure it.
Yeah. So actually, this from
Sinus pause.
here is twice this distance. So what do you consider it?
Sir, exit block then.
Yeah. Okay. Exit block and you sinoatrial exit block 2:1. Intermittent sinoatrial block 2:1. See here, this distance, this PP interval is what are the criteria to diagnose? It can be even Wenckebach phenomenon, but if you want to diagnose Wenckebach phenomenon, what is the criteria for sinoatrial Wenckebach phenomenon? What is the criteria for sinoatrial Wenckebach phenomenon? Anyone of you? What is the criteria for AV Wenckebach phenomenon, atrioventricular Wenckebach phenomenon?
For atrioventricular Wenckebach phenomenon is, sir, progressive increment in the PR interval with or without drop of the.
No, it has to be dropped.
We draw.
Progressive increase in the PR interval with one P wave fails to generate a QRS complex. Okay, right? Yes.
So, sir, incremental decrement of P. In case of sinoatrial Wenckebach, so there will be
No,
incremental.
don't go for sinoatrial Wenckebach. You described atrioventricular Wenckebach.
Atrioventricular Wenckebach, so there is a gradual increment in the PR interval with one drop, and whereas the RR interval will be, sir, decreasing, sir.
Okay, there is a progressive decrease in the RR interval. Very good.
And there is a
Progressive increase in the PR interval, decrease in RR interval.
Okay. Now there are four criteria. Two you have mentioned, two more are there.
P wave is blocked, sir.
No, that you have mentioned a progressive increase in the PR interval and one P wave fails to generate a QRS complex. Very good. Then we have mentioned that there is a progressive decrease in the RR interval.
And the first delay is the longest delay, sir.
Longest. Yes.
First delay is the longest delay. Fourth one, I'm not sure.
The four criteria are: one, there is a progressive increase in the PR interval and one P wave fails to generate a QRS complex. Two, there is a regular PP interval. PP interval is regular. Three, the RR interval progressively shortens. Four, the longest RR interval is less than twice the shortest RR interval. And the longest RR interval is the one which includes the drop P wave. Drop P wave. So these are the four criteria for the diagnosis of atrioventricular Wenckebach. If you interpret the same into sinoatrial Wenckebach, how can you mention the criteria for the diagnosis of sinoatrial Wenckebach? Anyone of you? What is the criteria for the diagnosis of sinoatrial Wenckebach? So here, in atrioventricular Wenckebach, P wave is the first chamber and the first electrical activity, and the QRS is the second electrical activity. And in a sinoatrial Wenckebach, what is the first electrical activity? In sinoatrial Wenckebach, what is the first electrical activity?
Right atrial activation.
Not right atrial activation, that is a P wave.
Okay.
Sinus node depolarization. First activity is sinus node depolarization. Do we have any surface electrocardiographic recording of sinus node depolarization? Do we have?
No P wave will be seen.
No P wave. No. So P wave is due to electrical activity of the atrium.
Atrium.
So when the sinus node is depolarizing, there is no surface electrocardiographic recording for us to detect it. So the sinus depolarization actually goes with the P wave if you want to put the same criteria as AV nodal Wenckebach phenomenon. And the next wave is P wave. In sinoatrial Wenckebach, P wave will be equal to the QRS complex of the AV Wenckebach phenomenon. Because the first one is P wave, where there is no equivalent in the sinoatrial Wenckebach. Next one is the R wave. R wave is equivalent to the P wave. So the criteria for the diagnosis of sinoatrial Wenckebach are only purely related to similar to what is R wave criteria. So the criteria would be 1. Progressive decrease in the PP interval. 2. The longest PP interval will be less than twice the shortest PP interval. So there are 2 criteria for the diagnosis of, because whenever there is a criteria for P wave coming, that P is regular, you cannot, there is no regularity of the P wave cannot, the criteria would be similar to, there is a regular sinus wave, but there is no sinus wave. So other criteria is that there is a progressive increase in the PR interval. So we cannot measure the sinus conduction from the sinus node to the atrium. So that 2 criteria cannot be applied. Only two criteria which can be applied to conduct to diagnose sinoatrial Wenckebach are: 1, there is a progressive shortening of the PP interval, and 2, the longest PP interval will be less than twice the shortest PP interval. If these 2 criteria are satisfied, you can diagnose a sinoatrial Wenckebach. Here, actually, this PP interval is this is the shortest PP interval, and this PP interval is twice this PP interval. I have measured it. So obviously, this is a 2:1 exit block. So this is a sinoatrial exit block 2:1, or you can put it as sinoatrial block 2:1 sinoatrial block, intermittent 2:1 sinoatrial block. It is an evidence of a 6 sinus syndrome. What are the other electrocardiographic criteria for the diagnosis of 6 sinus syndrome? What are the other electrocardiographic criteria for the diagnosis of 6 sinus syndrome? What are the arrhythmias associated with 6 sinus syndrome? One is sinoatrial block. What are the other arrhythmias?
Tachycardia syndrome.
What did you say?
Tachycardia syndrome.
Tachycardia syndrome. Okay, very excellent. Tachycardia syndrome. And in this tachycardia syndrome, what is tachy and what is brady?
Tachycardia will be atrial fibrillation.
Very good. And bradycardia will be?
Sinus rhythm.
Yeah, very good. Sinus bradycardia. Sinus bradycardia, intermittently atrial fibrillation occurring, that is suggestive of 6 sinus syndrome. Very good. Yes. What is other arrhythmias? Sinus bradycardia itself. If the patient is having sinus bradycardia, you must always suspect 6 sinus syndrome. If the patient is having associated symptoms of giddiness, and you can sometimes you can exercise these patients, and if they have got a negative poor chronotropic response, then that will make you suspect that the patient may be having 6 sinus syndrome, or the patient can have sinus arrest, intermittent sinus arrest. And also these are the 4 arrhythmias that can be present in a patient with 6 sinus syndrome are: 1, tachycardia syndrome; 2, the the sinoatrial conduction abnormalities, including sinus arrest. Sometimes you can have sinus arrest and sinus bradycardia. So these are the 4 arrhythmias that can be associated with 6 sinus syndrome. Okay, right. Diagnosis. What are the diagnoses that you can make this from this pressure tracing? Those 3 pressure tracings are given. One is LV tracing, aortic tracing, and left atrial tracing.
Sir, there is a gradient between left ventricle and aorta.
Very good.
And it is almost I can't say.
This is actually 20. Each one between the two lines, it is 20. So first line indicates 20 millimeters, next 40, 60, 80, 100, and above 100. Or it may be even more. I don't remember now. So what are the things that you can conclude by looking at the pressure tracing?
There is also a LVOT obstruction, as well as there is a the LA pressure is also raised above the diastolic pressure. So it could be there is a MR is also present, sir.
Very good. That's a prominent V wave. You should describe it. This is actually a very prominent V wave, and that may indicate that there is a large volume of blood is coming to the left atrium during systole, and it may indicate mitral regurgitation. Very good.
So it could be, sir, LVOT obstruction, sir, associated with mitral regurgitation.
Is it a fixed obstruction or a dynamic obstruction?
It's dynamic obstruction.
Why did you say it's a dynamic obstruction?
So because, sir, the peaking is early, not late.
Peaking is early. What do you mean by peaking is early?
Sir, the pressure tracing in the aorta, so the maximum gradient is seen early, not late, sir.
No, you can see the actually the pressure, the gradient is seen sometimes in the mid systole. It actually increases in mid systole.
In the mid systole.
How will you differentiate the fixed obstruction from dynamic obstruction?
Sir, bifid pulse.
No.
Bifid.
No. By looking at the pressure tracing. I'm
not able to recognize the terminology, sir. In LV we see the up and down pattern in dynamic obstruction, and in fixed obstruction we see slow rising followed by late peaking.
Late peaking, and
pattern.
one more.
Here in LV there is a sudden peak of there is a sudden increase in the there is a sudden peak followed by deep, and again there is a slow peak. Then this is a dynamic obstruction.
This is a dynamic terminal. See, in dynamic obstruction, actually initially the aortic pressure rises along with LV pressure.
LV pressure abruptly rise in the pressure.
There is a normal rise in the pressure along with the LV pressure, and then the obstruction comes and there's a gradient. While in a patient with fixed obstruction, from the beginning itself there will be gradient. So the initial rise of pressure in the aorta along with the LV pressure indicates that there is a dynamic obstruction. Initially there is no obstruction. Then the obstruction comes in. So this is a dynamic obstruction. So the presence of a normal rise of aortic pressure along with the LV pressure indicates that this is initially there is an obstruction, and then the obstruction sets in. There is evidence of a dynamic obstruction. And as somebody has rightly pointed out, there is a prominent V wave in the left atrial tracing indicating there is associated mitral regurgitation. This is a dynamic LV-OT obstruction with associated mitral regurgitation. So hypertrophic cardiomyopathy with mitral regurgitation. How can there be mitral regurgitation in hypertrophic cardiomyopathy?
Systolic anterior motion of mitral leaflet.
Same.
There can be systolic anterior motion of the mitral leaflet, and that can result in mitral regurgitation.
Yes,
okay, very good. Okay. Diagnosis. In what situation you can get this type of a pressure trace?
Sir, acute mitral regurgitation.
Acute mitral regurgitation. Very good. Why did you say it's acute mitral regurgitation?
Sir, V wave is very prominent and it touches up to the left ventricular systolic pressure.
Yes, almost equal to the left ventricular systolic pressure, more than 100 millimeters of mercury V wave So this indicates an acute mitral regurgitation. And one situation where you can have this is
Sir,
the capillary muscle rupture.
oh yes, it can happen in papillary muscle rupture.
plain mitral
But we in a papillary muscle rupture we won't go and do this tracing. But once this tracing is available, what is the situation where this can happen?
Sir, balloon valvulotomy.
MS.
Mitral valvulotomy.
Very good. In a patient where who is undergoing balloon valvuloplasty, sometimes there can be tear of the valve giving rise to acute mitral regurgitation, and this can be seen in such patients. Very good. Excellent. Okay, right. Okay, what is this?
So this is the broken Brown valve phenomenon.
Why? Why did you say that?
Sir, because sir, ectopic, after the ectopic beat,
Oh,
sir, we have to see the pulse pressure,
oh,
sir, which is increased.
oh.
So we have to differentiate from the fixed obstruction to the dynamic obstruction.
Hmm.
In case of sir, dynamic obstruction, the pulse pressure will immediately after the VPC, it will not increase, sir.
Hmm. Here, is it increasing or decreasing?
Yes, sir, it is increasing, sir. Pulse
Then why did
pressure.
you say it is broken brown wall Moro syndrome?
Oh, sir, sir, actually, I was knowing, sir, that after VPC, it is, no, sir, I was wrong, sir.
Hmm.
Means, I thought that this method is said to be as this one. No, sir. So this is a rather fixed obstruction.
Yeah, it's a fixed obstruction. You can see the difference. See, in this patient, from the beginning itself, the pressure is going. There's a difference between the LV pressure and the aortic pressure. See, aortic pressure is becoming gradually rising, while the LV pressure has already risen. While in the previous one,
Yes, sir.
It is almost similar.
it is initially it is occurring together, and then only it starts diverging. While in a patient with a fixed obstruction, from the beginning itself, the aortic pressure will be less. And here there is an ectopic beat, and following an ectopic beat, there is a post-ectopic beat, which indicates a significantly elevated LV pressure, and the aortic pressure also is elevated, unlike in broken brown wall Moro syndrome, where the beat following the beat following the ectopic beat will have a lower aortic pressure. What is the reason, Saroj?
Yes, sir. Sir, because sir, because of the ventricular ectopic, sir, left ventricular volume is increased. As a result, the force of contraction will be very high. So, sir, in case of dynamic obstruction, the obstruction will be more pronounced.
No. What will happen to the obstruction when there is an increase in the left ventricular and diastolic volume?
Sir, if preload is increased, then obstruction will decrease, sir.
Yes, when the preload is increased, the obstruction will decrease. So how can there be obstruction?
So the mean pressure has to be dropped. Aortic mean pressure has to be dropped.
Why? Because whenever there is a increase in the left ventricular and diastolic volume, then a dynamic obstruction, the obstruction will be decreased.
Yes.
And so more volume of blood can be pumped out, and there can be actually an increase in the aortic pressure.
Aortic pressure, sorry, sir. Increase in aortic.
But sir, because there is a increase in the left ventricular end diastolic volume, the force of contraction will also increase.
Yeah, that is a marginal increase only. More important is there when there is an increase in the left ventricular and diastolic volume. Of the two things, the more important is the greater end diastolic volume, which will result in less of obstruction.
And sir, that previous graph, I remember that terminal spike and dome appearance, sir, in LVOT obstruction, that dynamic obstruction.
Okay. No, but the question is now, let us answer this question. What is the mechanism of broken brown wall Moro syndrome or phenomenon? What are the hemodynamic changes in a occur in a post-ectopic beat? Then only you can analyze it. So what are the hemodynamic changes which occur in a post-ectopic beat? Saroj,
Yes, sir. So
what happens to end diastolic volume?
increased.
Increase. What happens to contractility?
The contractility will also increase.
Increase. Contractility and force of contraction are two entirely two different things. What is the difference between these two?
Sir, I don't know, sir.
Difference between contractility and force of contraction. Any one of you? What is the difference between contractility and force of contraction?
Contractility, sir, there is a normal there is no obstruction, and there is a normal contraction of the myocardium, and the force of contraction that LV has to pump against some obstruction like aortic stenosis or LVOT.
It has nothing to do with obstruction. Nothing. What is meant by what do you mean by force of contraction, and what do you mean by contractility? You should be very clear, because this is a basic thing in cardiology. Very basic thing. The force of contraction is the force with which the ventricle contracts. There are three important parameters which can change the force of contraction. They are: 1, end diastolic volume. It increases the force of contraction. 2, contractility. Contractility increases the force of contraction. And 3, tachycardia. Tachycardia also can increase the force of contraction by a trippy phenomenon. So 3 things can actually increase the force of contraction. What is contractility? Contractility is the intrinsic property of the myocardium to contract independent of the loading conditions. That is the definition. Contractility is the intrinsic property of the myocardium to contract independent of the loading conditions, which includes preload as well as afterload. Is it clear to you?
Yes, sir.
So you should not confuse between contractility and force of contraction. I will repeat. Force of contraction is the force with which the myocardium contracts, and this is influenced by 1, preload, 2, contractility, and 3, afterload. Not afterload, actually, to some extent, the heart rate. It is not the afterload. Afterload can help in emptying, but heart rate. 3 things which can change the force of contraction are preload, heart rate, and contractility. Contractility is the intrinsic property of the myocardium to contract independent of the loading conditions, preload as well as afterload. It is independent. That is known as the contractility. So in a patient with during an ectopic beat, the hemodynamic changes are increase in the preload, 2, increase in what happens to contractility?
Increase in force of contraction.
Yeah, contractility also increases. Why there is an increase in contractility in the post-ectopic beat?
Diastolic.
Frank-Starling law.
Huh?
Frank-Starling law.
Not Frank-Starling law. Frank-Starling law comes only in
Diastolic feeling, sir.
preload.
Preload.
Why there is an increase in contractility in a post-ectopic beat?
Sir, a long diastolic period, so venous filling is more.
That will give rise to only increase in the preload that we have already mentioned.
It is to do with sir, calcium.
Very good. The calcium release. There's more calcium is released, and also the more metabolites are available because of the longer diastolic phase. The more calcium release, and also energy, or also more energy is available, resulting in much stronger contraction. So contractility increases, and there is an increase in the force of contraction. A third thing that happens after, what happens to afterload? In a post-ectopic beat, what happens to afterload? Any one of you? Monica, are you there? Monica? Okay. Ronak?
Sir, afterload decreases.
Afterload decreases. So 3 hemodynamic changes in a post-ectopic beat are: 1, increase in the preload, increase in the contractility, and 3rd, decrease in the afterload. So let us look at the effect of these 3 hemodynamic changes on the dynamic obstruction. So when the preload increases, what happens to obstruction?
Decreases.
Decreases. When the contractility increases, what happens to obstruction?
Increases.
Increases. When the afterload decreases, what happens to obstruction?
Decreases.
Decreases. Eh?
Sorry. Afterload
When
decreases.
the afterload decreases, what happens to obstruction?
Increases, sir.
Increases. There are two hemodynamic changes which actually increase obstruction, and one hemodynamic change which actually decrease the obstruction. The preload increase will decrease the obstruction. The contractility will increase obstruction. Decrease in the afterload will increase obstruction. So the ultimate, the net effect is an increase in the obstruction, and that will result in a lower systolic pressure in the post-ectopic beat. That phenomenon is known as the broken burrow, Brown-Ward, Morrow phenomenon. Saroj, is it clear to you?
Yes, sir. Yes.
Yes. Yes. Sir.
So I'll repeat once more so that it is very clear to you. There are three hemodynamic changes in the post-ectopic beat. They are: one, increase in the preload, increase in the contractility, and decrease in the afterload. The effect of increase in the preload is a less of dynamic obstruction, increase in contractility, more obstruction, and decrease in the afterload, more obstruction. So two hemodynamic changes actually increase obstruction, and one hemodynamic change actually decrease the obstruction. Ultimately, the net effect is actually increase in the obstruction that will result in a lower aortic pressure because of the greater LV outflow obstruction. So in a patient with a dynamic LV outflow obstruction, post-ectopic beat can have a lower systolic pressure because of the higher obstruction. And this phenomenon is known as broken burrow, Brown-Ward, Morrow phenomenon. Okay, is it clear to you? There should not be any doubt about it. Is it clear to you, Saroj?
Yes, sir. Yes, sir. Yes, sir.
Ronak, is it clear?
Yes, sir. Yes, sir.
Okay, right. Okay, right. So here what is happening?
Sir,
Right.
here in post.
Pressure increasing, sir.
Increasing. So this is actually a dynamic obstruction or a fixed obstruction?
Fixed obstruction.
Fixed obstruction. And you can also see that unlike the previous one, see, the previous one, the initially pressure of the aortic pressure as well as the LV pressure rises together. They rise together. While here, what you can clearly see that from the beginning itself, the aortic pressure is less than the LV pressure. All over you can clearly see. So if the pressure rise, the pressure gap occurs immediately after the beginning of the pressure crossover, it means fixed obstruction. But if the pressure in the aorta initially rises along with the LV pressure, and then there is an obstruction, and that is suggestive of dynamic obstruction. Okay, right. Is it clear now?
Yes.
So this is the fixed obstruction, right? Hemodynamic data, cath data. Anybody can venture a diagnosis. What are the possibilities? Tell me the possibilities, and then you can, if you want, you can tell me the possibility and tell me why did you draw such a conclusion. Is there a shunt lesion in this patient?
No, sir.
No shunt lesion.
No
Okay.
shunt, sir. Sir, from the pressure sir, from the oximetry tracing, it looks, sir, sir, normal.
Okay.
And
No,
sir, in the pressure tracing, sir, we are seeing, sir, that
Is wide pulse pressure, sir.
White
There's a
there is
white pulse pressure.
gradient between sir, the A and V in the pulmonary
V is prominent, sir.
pressure. So in the wedge pressure, sir, the V is 34, sir.
Oh, yes, yes.
Very high, sir.
So what does that mean?
It means, sir, and A is also high, sir. It means, sir, there is a, sir, but there is a no gradient between the, sir, LA and LV. So both are 20.
Okay.
So, sir, B is more prominent, sir, whether mitral regurgitation.
Very good. There is a large volume of blood is coming to the left atrium. So most likely there may be an acute mitral regurgitation that can, or even subacute, acute on chronic mitral regurgitation, which have resulted in a prominent V wave, 34. Okay,
Yes,
right. Yes.
And sir, there is a no gradient between the left ventricle and the aorta.
Okay.
But, sir, aortic pulse pressure is very high.
Okay.
So, sir, and sir, in the right side, sir, also, sir, A and B, so they are more. Sir, it means there is a possibility that, sir, pulmonary hypertension is present or not.
No, there is some degree of pulmonary artery hypertension because it is automatically will be there because if the pulmonary artery wedge pressure is so much elevated, there can be passive elevation of the pulmonary artery pressure.
Yes, sir. So, sir, here possibly, sir, there is mitral regurgitation.
Very good.
And, sir, aortic regurgitation.
Very good.
This
And?
Mild PAH.
Okay, very good.
And, sir,
Possibility of?
Sir, oximetry data.
Okay, now do you think that there is a tricuspid regurgitation also?
Yes, sir.
Yes. So here the one first diagnosis.
Yes, sir, tricuspid regurgitation. B wave is prominent. Yes, sir. 12 is very high.
So the first possibility that you will think about is that probably there is a acute or acute on chronic mitral regurgitation, aortic regurgitation, and there is probably tricuspid regurgitation. That's it. Is there any other possibility that you can think about? I'm asking you a question. Is it ruptured sinus of Valsalva?
Ruptured sinus of Valsalva. RSVP. Sir, no, sir.
Oh no, why?
Sir, because, sir, in case of RSOV, then, sir, aortic pressure will be transmitted to the chamber which either RA or RV. Sir.
No, you can immediately rule out ruptured sinus of Valsalva on one finding. What will happen to oximetry data?
The saturation will fall down, sir.
There will be increased
fall down.
saturation in which chamber it is draining, sir.
No.
If
There will
it
be a
is
rise
draining
in
to
the
RA, then RA saturation will be high.
there will be a step up in to the chamber to which the sinus is rupturing. Mostly it ruptures to the right ventricle, or sometimes it can rupture to the right atrium. So you will expect a oxygen step up. There is no oxygen step up. So rupture sinus of Valsalva is out. So the diagnosis: mitral regurgitation, aortic regurgitation, and tricuspid
Regurgitation.
Okay, very good, excellent. So whenever you get a hemodynamic data, you immediately analyze not only the oximetry data, but also quickly look at the pressure data, and you should be able to draw conclusions properly. Okay, is it clear to you how we have concluded that there is a mitral regurgitation, aortic regurgitation, and maybe mild or low moderate tricuspid regurgitation? Okay, right, we'll go to the next one. Diagnosis. This is simple. You should not have any difficulty in diagnosing it.
Sir, PDA?
Here, there
Why
is
did you say PDA? You explain it, then I will accept it. You have to explain it.
pulmonary artery, sir, there is a rise in the saturation.
Saturation, sir.
There is a step up.
There is a step up in pulmonary artery saturation.
Very good. There is a significant step up in the pulmonary artery. Is it significant?
Yes, sir.
Yes, sir.
Why is it significant?
So it is 755. So at the level of great artery, it is more than 5.
So it is a 755 is for multiple samples. Multiple samples in the atrium more than 7. Multiple samples in the ventricle more than 5. Multiple samples in the arteries more than 5. Single sample.
Sir, 11. 11. First is 11, sir, at the atrium.
In the ventricle.
7 and 5.
Okay. It is in the at the level of the artery, both single and multiple is 5. In the ventricle is 5 and 7. In the atrium it is 7 and 10, or sometimes people even say 11, 7 and 10. So here there is a significant step up from RV to pulmonary artery, about 10 or 11. So indicating communication is coming from an oxygenated blood is reaching the pulmonary artery. So commonest is patent ductus arteriosus. Okay, right? Yes. And is there evidence in the pressure tracing that this could be patent ductus arteriosus?
Yes, sir. Because the pulse pressure is high, 120/40.
Very good. So there is a significant pulse pressure also. That also indicates that the patient is having some the aortic runoff, indicating patent ductus arteriosus, which hemodynamic abnormality as well as oximetry data suggests patent ductus arteriosus. Very good. Okay. Diagnosis.
So restrictive cardiomyopathy.
Yes. Give the name.
Amyloidosis.
Amyloidosis. Very good. Excellent. Why did you diagnose amyloidosis?
Sir, a thickened and shiny interventricular septum,
Okay.
biatrial enlargement.
Okay.
Then in Doppler, there is a diastolic dysfunction, and in tissue Doppler, there is a
E by E prime 21.7. It is very high.
Very high. E by E prime is 21 points, indicating significant diastolic dysfunction. And also you can look at even the intrator septum is thickened. The only condition where there can be all over the myocardium there is speckled appearance, thickened myocardium. And what will be the cardiac MRI picture? Late gadolinium enhancement. What will be the
apical sparing? Sir, apex will be spared.
Oh, that is when you are doing GLS. There is known as cherry on top. In GLS. That is, I am asking in cardiac MRI. In GLS, apex will be spared. There will be good contraction at the apex, and if you track it on a bullseye, you will be seeing cherry on top phenomenon where the center part will be red and surrounding areas there will be evidence of hypocontraction. What will be the
subendocardial late gadolinium enhancements?
Yes. Actually, unlike this is one condition where the fibrotic changes can be there throughout the myocardium, subendocardial, subepicardial. Normally, you get the fibrotic changes, the late gadolinium enhancement in the subendocardial region in patients with ischemic heart disease. But here, this can happen in patients with amyloidosis, where there can have diffuse late gadolinium enhancement from endocardium to the epicardium. Treatment. Is there any drug which is available, and what are the different types of amyloidosis?
So one is wild type, another is
wild senile type.
What is senile? Light chain, senile one, and also familial amyloidosis, where actually they are described as TTR. And then there is a localized amyloidosis which can affect the atrial musculature. And finally, there is a secondary amyloidosis which is secondary to a chronic inflammation which does not usually affect the heart at all. Is there any treatment for amyloidosis?
Sir, newer siRNA.
No,
sir, I don't remember, sir.
Yes, sir, one drug has come, start name with P. T.
Oh, very good. What is the name of the drug?
Sir, forgotten.
Tafamidis. Tafamidis. If the name of the drug is tafamidis, this can be used in TTR. There is some evidence that it is not yet not yet accepted for regular treatment, but this is being tried, and there is some evidence that in patients with TTR type of amyloidosis, this tafamidis is beneficial. So in the examination, the examiner can ask you, is there a new drug for the treatment of amyloidosis? You should know that. That is all, but it is not so far being regularly used. Otherwise, the treatment is treatment of heart failure, and some of these patients, especially if the patient is young and the patient is having heart failure which is not responding to treatment, then these patients can be subject to. Usually, device treatment is not beneficial in these patients, especially the resynchronization therapy and all those things are not useful in these patients, and even ICD implantation is not useful. But if the patient is having trouble and they are young, probably cardiac transplantation also may be thought of. Okay, very good. Okay, now we'll go to the next one. Okay. Diagnosis.
Coronary sinus rupture.
Coronary sinus rupture. Why did you say rupture?
Submitral ring. Coronary sinus is prominent in the fourth chamber, but sir, in the plaque view, we can see, sir, that is the submitral region.
No, this is a coronary sinus. What is this? What is these two?
This is a descending aorta, and this is coronary sinus.
This is coronary sinus. This is descending, and coronary sinus is very large. So, what are the conditions in which coronary sinus can be large?
LSVC.
LSVC. And if there is any anomalous communication is coming to the coronary sinus.
Unroofed ASD.
Unroofed ASD coronary sinus will not be enlarged. They usually will have a
Directly drill into our
left to right shunt. If there is a coronary artery fistula, a coronary cameral fistula joining the coronary sinus, can have a large coronary sinus and can have a continuous flow. And how will you make out? Is it a left SVC or is it a coronary cameral fistula?
Sir, bubble test.
Yeah. How will you differentiate?
Sir, with bubble test, within 3 cardiac cycle, it is appear in normally it is appear in right atrium. But if it is if it is appear before right atrium into left atrium, then it is a diagnostic feature of LSVC.
No, wrong. That's not correct. Yeah, in LSVC, it will not go to the left atrium. That is anomalous connection of the coronary sinus.
We need to give the bubble saline on left arm, sir. And then we'll see the contrast first coming to the coronary sinus and draining into the RA.
Right, very good. That's the answer. If you do a contrast injection into the left arm, if the contrast appears in the coronary sinus and then in the right atrium, that is suggestive of left SVC. Normally, the contrast will not go into the coronary sinus because it will drain into the right atrium only. So, if in a patient with a left SVC, if you inject contrast bubbles into the agitated contrast bubbles into the left arm, if the contrast appears in the coronary sinus first and then subsequently in the right atrium, that is suggestive of persistent left SVC draining into the coronary sinus. So you are seeing a bubble injection here from the left arm. What do you find here? Is the contrast coming to the coronary sinus or is it coming to the right atrium?
No. So it is coming to the right ventricle.
It's right ventricle. It is first coming to the right atrium and then to the right ventricle.
In the coronary sinus.
There only it actually it fills the right atrium and then regurgitates into partly into the
Coronary
sinus. It does not directly come to the coronary sinus. So this is not a anomalous drainage of the left SVC into the coronary sinus. And also you can see a continuous flow here. And also you can the pressure tracing, the Doppler signals are also available. So this was a case of coronary arteriovenous fistula or coronary cameral fistula into the coronary sinus. Okay, we'll go to the next one. Any comment about the management?
No, usually there is patient is remain asymptomatic throughout the time, so no significant management for this.
Okay, most of the times actually coronary cameral fistula in the initial phase it will be asymptomatic, but over a period of time they gradually grow in size and the shunt and we can have a steal effect on the coronary blood flow and these patients can have effort angina. They may be initially asymptomatic, but they may develop effort angina. So it may be worthwhile if it is a when the communications become very huge. Sometimes it may be difficult to do a device closure, coiling or device closure. So if the patient is amenable to for device closure, I think these patients can undergo device closure so that the coronary cameral fistula is completely blocked off and there is no question of patient subsequently developing a coronary steal effect and anginal symptoms. Over a period of time, it can progressively increase and the patient can become symptomatic. So once the coronary cameral fistula has become very huge, sometimes it can become really huge and sometimes at that time a coil closure may be or a device closure may be difficult. And it may be worthwhile trying to find out whether the patient's the coronary cameral anastomosis or the coronary fistula can be actually completely device closed. So that can be tried even when the patient is not having too much symptoms. They can progressively increase the shunt and they may become symptomatic at a later date. Or if it is only a very small one, then you can leave it alone and later consider a device closure if the patient is becoming symptomatic. Both can be tried.
So this LSUC can be seen in suprasternal view also, no, sir?
No, it's difficult to see in the suprasternal view.
Doppler.
What you can do is that when you see the coronary sinus, you make it long axis. You see the short axis view in the coronary sinus, and then you make it long axis. Then you can track the left SVC.
Okay, sir.
Okay.
The endocardial cushion defect.
Yes, that is not enough. Not enough.
Complete.
Yeah, you should use the word complete AV canal defect. What do you mean by complete AV canal defect?
There is no septum intermediate.
So they will have a ostium primum type of ASD. They will have
Inlet VSD.
inlet VSD.
And the cleft
mitral resulting in mitral regurgitation. Cleft tricuspid valve resulting in tricuspid regurgitation and single
bridging leaflet.
Single AV valve. So all these things should be described. See, when you say there is a complete AV canal defect, it means that there is ASD, VSD, a single AV valve, and also MR and TR.
Yes.
It becomes a complete AV canal defect. This is a complete AV canal defect, and complete AV canal defect is very often associated with
Down syndrome.
Down syndrome. This patient had Down syndrome, and in a patient with Down syndrome, when you are hearing a murmur, always think of the possibility of total AV canal defect. Sometimes they may have only they might have developed pulmonary arterial hypertension, and you may hear only a ejection systolic murmur or a short murmur. Even in that situation, you must always suspect the possibility of total AV canal defect. Okay, very good. Diagnosis. This is a transesophageal echo. What is the diagnosis? What do you find there? What is the structure that you are seeing? What is this structure? What is this structure? What is this structure?
The pulmonary embolism.
Pulmonary embolism.
Left atrial appendage thrombus.
Very good. It is left atrial appendage clot. This is the left atrial appendage, and you can see a clot filling the left atrial appendage. This is a clot in the left atrial appendage. You can see that there is a evidence of turbulence in the appendage region as well as in the left atrium. Smoke seen. So this is a pre-thrombotic state, and there is a thrombus seen in the left atrial appendage. So there is a thrombus in the left atrial appendage. What is this suggestive of? And where do you get this type of echo appearance?
These are B lines, sir.
B line. Not okay. You can say it's B line from the lung.
Pulmonary edema.
Pulmonary edema.
This is pulmonary edema when you are doing a lung scan, and known as B line or B lines suggestive of pulmonary edema. Normally, also you can see up to 2 to 3 B lines, but if you are seeing more than 5 and not, that's highly suggestive of pulmonary edema. When a patient is coming in with acute breathlessness, suppose you have got a doubt whether it is respiratory or a cardiac cause, then ultrasound examination definitely will help you. And if you can pick up the B lines on the lung field, it is highly suggestive of pulmonary edema.
Sir, one thing, sir, please trace which they mean the B line, sir, from your cursor.
Beg your pardon?
Sir, please trace with your cursor which they are meaning the B lines. Sir.
Oh, these are all B lines. See, you can see that these lines.
Oh, sir, longitudinal lines.
These are all B lines.
Okay, okay.
These are all B lines.
Thank you.
Some people consider the lung comets also, because they are like comets, because the light is going. So some people call it as a lung comets. B lines, lung comets, all indicate, and you should be able to see more than 5. There's plenty. 1, 2, 3, 4, 5, 6, 7, 8, plenty of them. And highly suggestive of pulmonary edema. B lines. Diagnosis.
Severe tricuspid regurgitation
Okay, severe tricuspid regurgitation.
with mitral valve thrombosis.
Mitral valve thrombosis.
No. Mitral.
Mitral valve. So whether prosthetic mitral valve.
Prosthetic mitral valve.
What prosthetic mitral valve? You have to complete.
Sir, mechanical prosthetic.
Mechanical prosthetic.
Which mechanical prosthetic valve?
So looks like ball and socket.
Okay, caged ball and socket, caged ball, mitral prosthetic valve, tricuspid regurgitation. What else?
Sir, thrombus in the LA and sir mitral valve.
There is no thrombus in the leg. There is something more. You should develop the habit of looking at everything, even if you are diagnosed 1 or 2 conditions. You are doing post graduation in cardiology. You should be able to pick up all abnormalities. Don't get satisfied with one abnormality.
Sir,
what is this?
The tricuspid valve stenosis.
Yes, there is a doming of the tricuspid valve. There is significant tricuspid valve stenosis. So 3 things: tricuspid stenosis, tricuspid regurgitation, prosthetic mitral valve, caged ball. Okay, right. Good. Okay, right. Diagnosis.
Anterior papillary muscle rupture.
Can you diagnose papillary muscle rupture from this?
No.
It's difficult. Otherwise, you should be seeing papillary muscle moving in and out of the picture.
This is short axis view showing that hypertrophy ventricle with mild dilatation also and the jerky movement.
There's no jerky movement. The LV is dilated, you are right. So what is the cause of dilatation?
Non-compactions.
Non-compaction, very good. It is non-compacted LV. How do you diagnose non-compaction?
Trabeculation more than 3.
No. If you look at the trabeculations during diastole, and you find that the non-compacted portion is twice that of the compacted portion, that is diagnostic of non-compaction. It is a partial non-compaction. It's not a total non-compaction, but you can still see the crypts here. You can see crypts here. Everywhere there are crypts. So it is non-compaction. Now, what are the problems of non-compaction?
Sir, it can precipitate thromboembolic.
Yes, in the crypts there can be thrombus formation and it can give rise to embolic episodes. 1, 2. Non-compacted portion is a weak myocardium, and these patients can develop progressive
Systolic failure.
systolic dysfunction, LV failure, and this patient can have problems related to something like cardiomyopathy, dilated cardiomyopathy. And there is some hereditary factor, and hereditary factor also is playing an important role. So many of the patients with non-compaction can run in families. So parents, if the parents are having non-compaction, there's a possibility that children also can have non-compaction. So non-compaction is diagnosed by finding that compacted and non-compacted ratio, which is non-compacted should be twice that of the compacted. This patient can develop progressive LV dysfunction. They can have embolic episodes, arrhythmias, all those things can happen. Okay, right, yes. This is simple. You should be able to diagnose without any difficulty. Diagnosis.
PDA, sir.
PDA, very good. It's a PDA. You can see that it's a continuous murmur, and murmur peaks at the time of the second sound. The gradient is maximum at the time of the second sound. So this is a case of PDA. Very good. Diagnosis.
Pulmonary embolism.
Yeah, very good. Embolism. You can see the RV outflow is dilated. You can see the McConnell sign where the apical portion of the RV is contracting, while the free wall and the basal portion is not. The free wall is not contracting. So McConnell sign, and also distended and dilated, inferior vena cava. Very good. Diagnosis. Diagnosis. This we should not have any difficulty.
Device is saying, sir, whether this is a
Subaortic stenosis.
Biotic stenosis.
No, sir.
What is the view? Is it what is the view? This angiogram is done in which view? RIO view, LAO view, what view? In which view is this angiogram done? Is it in RI view, LAO view, AP view, lateral view, or which view?
So lateral view.
Not lateral view, it is an LAO view. Whenever you are seeing differentiating between the right side chambers from the left side, where is the injection done?
Sorry, LV.
LV. The injection is done into the LV, and when you are differentiating, separating LV from RV, it is always happens in LAO view. So this is an LAO view. And what are you seeing there?
VSD close.
VSD. There is a large prominent VSD seen. And what is the next one?
The device closure of the VSD.
VSD has been closed with a,
I think Watchman device.
yeah, not Watchman device. It's a VSD device closed.
Implants.
Sometimes people even use the ASD device for VSD closure. This is a VSD closure, muscular VSD closure.
Implants.
It's a VSD closure. I'm not sure. It's a VSD closure which has been done successfully. Okay, what is this?
So the two chamber view with large thrombus, LV thrombus.
That's what is this? What is the test being done? This is a contrast.
The contrast echo done for the knowing the apical clot.
Yes. It is a sono view. We have used the sono view contrast to study the left ventricular cavity in order to confirm or rule out left atrial, left ventricular apical clot. So this patient is having a LV apical clot. Okay, good. I think that's all. So any doubts about the things that we have seen today? Do you want one more session on spot test?
Yes, sir.
Next class also?
Yes, sir. Yes, sir. Yes.
I think if we can have one more session, I think we can cover most of the spot tests which can be shown in the examination.
Yes, sir.
So, and after that, we'll go back to the clinical examination, clinical discussion.
Yes.
Is that all right?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So next class also we'll have some about 30 spot tests, and that will give you a little more idea about the diagnosis and how to discuss it. Any doubts about things that we have told today?
No, sir. No, sir. No, sir.
Okay, right. Okay, good night. Good.
Good night, sir.
Good night.
Thank you, sir.
Thank you, sir.
Good night. Good night.